Welcome everyone to the Countdown to Keele webinar series. We will give attendees a couple of minutes to sign on before we start. For those of you just joining, we are giving everyone just another minute or so to sign on, and then we'll get started. Welcome everyone. I'm Kelly Grant, Vice President of Business Development and Admissions for Caron Treatment Centers. We're excited to have you today in the third of 6 webinars focusing on our new state-of-the-art 100,000 square foot medical center in Delray Beach, Florida, the Keele Center. Thanks for joining us as we count down to Keele. First, some housekeeping items. Today's webinar will be conducted in webinar format, meaning we cannot see or hear you, but we do want to engage with you. So please use the Q&A feature in the bottom right-hand corner of your screen to ask questions. We will do our best to get to all of those, but if we run out of time, please know that someone from Caron will follow up with you. And please note that today's presentation does not include continuing education credits. And lastly, this webinar is being recorded and it will be posted to Caron's YouTube page for future reference. We will now show you a short clip of the construction of the Keele Center and our older adult program. So I would like to take a moment to say that while we are experts at addiction and co-occurring behavioral health treatment, we are not experts at technology. So unfortunately, there wasn't sound with that video, but there is sound. So that will be posted on our YouTube page. So apologies that you didn't hear it, but hopefully you could read along and you saw the pictures. Today we have Dr. Barbara Krantz, who is our Director of Addiction Medicine at Caron, Florida. Dr. Krantz is an expert on both national and local pain medication epidemic and the medical science behind the disease of addiction. Dr. Krantz has worked in the recovery field for more than 30 years. Prior to this, she was both an ER physician as well as a family practice physician. She's lectured on numerous topics, including the biochemistry of the brain as it relates to addiction, and is an advocate for neuroimaging to effectively diagnose and treat the disease of addiction. She's led collaborative studies for Scripps Medical and the University of Miami to identify effective and innovative treatment therapies and relapse triggers. And in 2010, the American Society of Addiction Medicine inducted Dr. Krantz into its Distinguished Fellow Program for her substantial and lasting contributions to the field of addiction medicine. The Palm Beach County Medical Society honored Dr. Krantz with its Heroes in Medicine Award for her leadership, philanthropy, and commitment to the field of medicine. And the Medical Review Officer Certification Council certified Dr. Krantz as a medical review officer. She's on faculty for the American Society of Addiction Medicine, and she's a member of the American Medical Association, American Medical Women's Association, American College of Family Practitioners, American Osteopathic Association, and the American Society of Addiction Medicine. She has quite the pedigree. Next, we have Sharon Matthew, who's the clinical advisor to Caron's older adult program. Sharon is the former clinical director of the older adult program at Caron, Pennsylvania. She worked at Caron for more than 25 years, and fortunately for us, she has stayed on to be a clinical advisor to the program, as well as the design and implementation of the older adult program at the Keele Center. And she is an advanced certified relapse prevention specialist, a certified clinical supervisor, a certified sex addiction therapist, and a certified multiple addiction therapist. Sharon was included in the chronic pain programming for adult patients, which is designed to treat chronic pain with addiction-free pain management and relapse prevention. And Sharon's national presentations include effective treatment for addicted older adults and caregivers, boomers and addiction, super aging, women in recovery, healing the shame, addiction interaction disorders, workshops on early recovery, and detaching with love and self-care. But before I hand it over to these incredible women, I would like to show you renderings of the community at Keele Center. First, we're going to see a slide that features a detox room. This will offer ADA-approved hospital beds for our patients that have mobility issues. And here we have a private room where our patients will stay once they're stabilized and mobile. If they need continuing support, we can transfer the hospital bed into their room on the older adult unit, just to keep them comfortable for the duration of their stay. And featured here are just some of the amenities that will be offered at the Keele Center that our patients can access. These photos show our fitness center, salon, and also our massage and acupuncture areas. And while all of our patients at the Keele Center will have access to our pool, specifically for our older adults and any patient with mobility issues, chronic pain, we will also be offering aquatic therapy. And additionally, you see our dining room, and we will be able to meet many different dietary needs through the Keele Center. So I will now hand the program over to Dr. Krantz, who's going to describe both the medical process, and then Sharon Matthew will describe the clinical program. So thank you both.
Thank you, Kelly. And thank you to everyone joining us today to learn more about our Caron's older adult program at the Keele Center and how this medical program meets the needs of patients who are of a certain age and or have significant co-occurring medical issues. The program is designed to be inclusive of patients who are physically and or cognitively compromised, usually as a direct result of their addiction and co-occurring issues, such as chronic pain or medical issues, which are part of the normal aging process. We use a non-confrontational approach, treating patients with dignity, respect, and care. As Kelly has already noted, that we have 24/7 nursing staff, and the unit is designed for safety, as well as all rooms are private and they are ADA compliant. Treatment. So let's talk about the treatment of the older adult. Treatment of the older adults essentially has a very strong medical component from day one. And this is important because it may even entail a longer detox program because of physiological changes that occur as we age. Older adults have a higher risk for medical consequences because, again, of the physiological changes that are occurring, plus the use of any addictive substance. If we add effects of the alcohol or any other addictive substance, we can see multiple issues, because then you're adding an addictive substance on top of a normal physiological change that's occurring as we age. So I've had many patients come to me and say, doc, honestly, I'm drinking 2 glasses of wine. I was actually drinking maybe, 3 glasses of wine 20 years ago, and I don't understand why I don't feel well. And I seem to be, more unstable the next day. Well, essentially, it is a medical issue. So I talk to them and tell them, you're really getting more bang for your buck. When we age, we normally decrease an enzyme in our stomach that breaks down the alcohol. So it's called alcohol dehydrogenase. When you add alcohol to that, then what you're doing is you're actually maintaining a blood alcohol level in your system that would be higher than it was when you were younger. So you may be able to have drank, a bottle of wine or even 2 bottles of wine when you were 40 or 50. And now at 60, 65, 70, you're drinking 2 glasses of wine and your blood alcohol level is maintaining through the day because of the changes, the physiological changes, again, that happen with aging. The other thing that we have to be aware of when we have a patient come into the detox unit is that we're looking at different drug-drug interactions, but we're also looking at most drugs all drugs actually will be detoxified through either the kidney and or the liver or both. So we're looking again what their physical function is by doing lab work. We do that on day 2, actually. And so we'll have all that information so we can speak to the patient why this drug or medication may not be appropriate for them, as well as the alcohol and or other addictive substances that they're coming in with. Again, as we age, insomnia and problems with restorative sleep are an issue and become more of an issue. Patients don't have to get up perhaps to go to work, so they can sleep longer, or they may be napping during the day. And there's great commercials on television for every sleeping pill that's known to man. And again, the prescription sleeping pills, the patient may go to the doctor and say, doc, I'm really having a hard time sleeping. Can you help me with this? So they give them a prescription for Ambien in all good conscience, but they don't understand that they may be drinking, again, a half a bottle of wine a day, or they're using Xanax or Ativan from another physician. So the synergistic effect, the cumulative effect of those drugs has a significant impact. The other thing, as we age, actually we get decreased cerebral blood flow. And that's with normal aging. And that's really because of the vascular disease, but it makes the patient that's coming into treatment actually more susceptible to cognitive issues. So, grandma who has been at the top of her game and now is like really struggling to find words or struggling to remember what she did with her keys or something like that. The effect of the substances, alcohol and other addictive substances, especially the benzodiazepines, the Xanax, Ativan, Klonopin, Valium, have a very significant effect on the aging brain. The other thing I see a lot, and I saw this in the emergency room actually quite a bit, was decreased cardiac reserve in cardiomyopathy and arrhythmias. And what I mean by that is, again, as we age, the normal physiological changes that occur, we get, our heart effectiveness of the pump action of the heart is reduced. And therefore that even can lead to cardiac arrhythmias. There's a name for this. It's called holiday heart syndrome, where the patients are going out on a fishing trip to the Bahamas, and it's their, once a year fishing trip. And they've been doing it for the past 30 years. And now they're in their 60s, maybe even 70s, and they go and we would get them in the emergency room coming back because they went into an arrhythmia, they went into atrial fibrillation, and it was because of the alcohol intake that they were imbibing on their fishing trip. So again, drug-drug interactions are extremely important to be aware of, to understand, and to be able to explain to the patient that this is a result of this, this, and this. Baby boomers are definitely reshaping the older adult population. By 2030, all baby boomers will be at least 65. I am a baby boomer. As we age, we may be experiencing more arthralgias, other co-occurring medical illnesses like diabetes or hypertension. But baby boomers essentially have had more exposure to illicit drugs in their youth. You know, the old slogan, drug, sex, and rock and roll. I remember that clearly. Or the Timothy Leary generation. They've usually have had a longer history of lifetime substance use, where maybe it was manageable at one point in time, but again, you add the physiological changes of aging to the mix and the patient's having a problem. So for both groups now, the aged baby boomers and the older adult, we're seeing again, alcohol, primary drug of choice coming into treatment, benzodiazepines, again, the sedative hypnotics, including the sleeping pills, so Xanax, Ativan, Valium, Klonopin, Ambien, Lunesta, and also the narcotics, the pain medications, oxycodone, are probably the most frequent substances that we see that need detox. Aged baby boomers may be presenting with illicit drug use also. I just had a gentleman, 74 years old, and I was surprised, and I've been in the field a long time. And he had done, he was in finance, had done a lot of cocaine in his early youth, probably even to maybe his 30s, 40s. And when he presented to treatment, he came in with methamphetamine. Now, that's not a great drug to take at 74 because of heart disease and cardiac arrhythmias. But again, they've had more exposure in their youth to illicit drugs. So perception of safety with prescription drugs and drug-drug interaction is discussed with all patients. Our patients, when they come into detox, can stay on the detox floor for however long they need to, but they also will move to the residential community on the 3rd floor of the Keele Center when medically appropriate. And as Kelly already mentioned, there are hospital beds that we can put in the private rooms there. So all of their needs will be met. At Caron, we are able to meet the challenges of mobility and chronic pain starting on the detox unit. So a CNA, a certified nursing assistant, will be assigned to each patient as medically indicated. And this will help with not only mobility needs, but also orienting the patient to their surroundings. We also will assess them right up front for physical therapy. We have physical therapy in-house, which is awesome. So the physical therapist will come to them. The treatment team will discuss the plan that they may need. And then the providers, the physicians, nurse practitioners will actually assist with the pain and schedule appropriate modalities. They will also have a concierge lab profile done and discuss with the patient. We even do cortisol levels, stress hormones, will help us understand what's going on with the patient and any nutritional or dietary needs that we may need to facilitate while they're in treatment. So that's the medical part in a nutshell. There's more to it than that. But now I really appreciate you being on the webinar and thank you so much. And I will hand it over to Sharon, who is our clinical expert on the treatment of older adults. Thank you, Sharon.
Thank you so much, Dr. Cranston, for that awesome overview. And you hit the nails on the head, to say the least. And there is so much more. I always say older adults is a very complicated affair, and you have to sift out what's going on. And that's why we designed the program early on to treat the mature older adults. And it was designed to treat them also with dignity and respect. It's very much a non-confrontational approach because they just won't tolerate it, nor do they, they need respect and dignity because they've lived their lives. The people that we treat are mostly retired, some still working. They definitely usually have families attached to them, adult children, several of them, and grandchildren. They have similar life experiences, and that's why this group bonds together quite well. They all have experienced possibly losses, possible chronic pain issues, lack of purpose, and that's just to name a few. They're able to relate to one another due to their life stages of life. And then Dr. Krantz mentioned the chronic pain. Many of the older adults do suffer from chronic pain issues. It's very prevalent in this population, either from injuries or genetics. Some patients become physically and psychologically dependent on a medication, and they also definitely medicate with alcohol. The modalities we use to treat chronic pain, she's already mentioned. It is a very much interdisciplinary approach. All of Caron really is interdisciplinary, but this really is. To another degree, so to speak. Medical massage is offered, acupuncture, physical therapy on site for those who need it, weekly process group in which they can learn how to develop coping skills other than using an addictive medication. Spirituality is huge in this realm, not that we don't do that throughout our programs, but spirituality is really needed because what this population needs is hope. They need hope that it can get better. Individual wellness consults are occurring all the time with the experts on the team. And as she mentioned as well, and Kelly at Keele, there will be aquatic therapy, and water therapy is excellent for this population. We also use medication assisted therapy, which is monitored by the excellent medical staff. So cognitively, that was always what stood out to me. So many patients come in with cognitive issues, memory loss, and initially, we are not sure what that is. Is it alcohol related? Is it due to their pill use? Is it the normal aging process? Or is it the start of cognitive decline, such as dementia? So testing is completed initially and when they come in, and then throughout treatment, we try to get a baseline of what might be going on. And most times what we watched was that there was progress throughout treatment. As they start to physically get better, cognitively started to improve as well. And if not, further testing is absolutely completed and offered. And then that also helps with the continuing care plan, which is labor intensive. It has to be the right fit. It has to be the right place to refer them to with the next steps of maybe neuropsych testing and that kind of thing. So medical conditions, Dr. Krantz did a great job of talking about those, and what we see is most are medically compromised. And when they first come into treatment, what we see also is they come in possibly with co-occurring conditions such as heart problems, diabetes, and if what we watched tremendously at Caron PA was the diabetes was so exacerbated by their alcohol use, numbers off the charts, not eating nutritionally. So we also have a dietitian involved with the care as well. So many are referred to us as well because of falls. What we watch is falls. They go to maybe a hospital setting. And then while they're there, they can see maybe their labs are off kilter and then oftentimes referred to treatment. And it does take time for them to rebound. This is a slow, steady process. The withdrawal process managed very carefully by the experts in the medical team. It's done very slowly. They are monitored throughout treatment about appropriate medications, and then treatment modalities help them improve and keep, our goal is actually to get them up and moving and progress through treatment, of course. So through the fact that we have nursing care 24/7, we have been able to take very compromised cases that sometimes were refused treatment at other settings. So that piece is a very much of a plus. Many of them have trauma from years ago that was never looked at, unresolved trauma, things such that might have occurred early on in their lives, such as physical, verbal, psychological, or sexual abuse or neglect. They seem to push it down, get busy with their lives, don't look at it, don't address it, and they have maybe been medicating with drugs and alcohol. We assess patients, then if appropriate, they attend the trauma educational group, trauma expressive art. Then if appropriate, they could possibly get cognitive processing therapy as well. That's done individually by our trained staff. It's powerful really to see the older adults do all this heavy duty work, because once they go through that process, they become lighter. They seem to have ability to breathe now. It lowers their PTSD symptoms if that's one of the issues. And this allows them also to make room for their own recovery. Grief and loss is a huge component of this program because many people have suffered a loss, whether it be the loss of a loved one or the loss of when they retire, loss of purpose, loss of their identity. But that's all anything I knew. So they have time on their hands. They use the word bored a lot, and it's just to fill a void. So sometimes they've been functioning with their alcohol or drugs, and then this is the sort of catalytic event that fuels it. So we provide individual counseling with the spiritual staff, and also they have grief and loss groups throughout their treatment. Family of origin, it appears that people say, well, why bother looking back at that? And you would have patients, well, why am I talking about that? Well, family of origin is what I think drives the bus. Family of origin, you have to look at how you grew up, what the core messages were, because that actually carries you through your lives. The patients are accustomed to not sharing these things because they don't want to discredit or devalue their parents. And what we do is also look at the unmet needs they might have had, and then the family dynamics, which then sort of rolls into their own raising of their children and carries through that way. So that is a very powerful group, and it's well received. After they understand the process, they seem to be more open to it. The family work, and I've done family work throughout my career at Caron, but I tell you, I have never done such heavy duty family work as with the older adult population. They might have a spouse of many, many years. Many of our patients were maybe married 50 years, 45 years, 40 years. Siblings are involved in treatment. Adult children and grandchildren are involved, all of whom have been very much feeling helpless and scared, not knowing what to do. And many of them for a long time have been in their own type of denial, just like the patient has been in their own type of denial. So we provide weekly sessions with the weekly calls to the family sessions throughout treatment. Family education program is also provided, and weekly updates to the family, which includes the family therapist calling the family members and asking them what they are doing for their own self-care. When you are in a caretaking role, you really forget about taking care of you. And also, it's not only exhausting, but they've maybe been doing that role for a very long time and don't know how to step out of that role. The treatment modalities that we use are very much, as I said, an interdisciplinary approach: medical, clinical, psychological, spiritual, and also the wellness team. We use cognitive behavioral therapy, reality therapy, getting them to tell their story. And I used to tell my team, get them to have the conversation with you. And those who are cognitively impaired actually respond to that as well, because they can tap in to those stories a long time ago. Maybe they don't have immediate memory, but they can go back and remember what it was like some time ago. So that's really well received. Dialectical behavioral therapy, DBT, using your wise mind instead of your emotional mind and your rational mind, having a combination of those and using your wise mind, because we have to have all those components together to make a good decision. Radical acceptance, very much a key component of this program, because there's a lot of things that come up through life that we have to accept, and some people struggle to do that. The willingness portion, and then one of my favorite lectures to present to them was the purpose and quality of life. What do you need? What do you want? What's going to get you up and moving in the morning now that you don't have your drugs or alcohol? What's going to be the driving force? They respond really well to experiential therapy. They like to know the how to do things. They want, now you're giving this education, but they want to know, how do I apply it? So I used to do a coping skills group and use props. I would talk about the stressors they're going through and then ask them to go pick a prop that might help them with that stressor. That really stands out to them, and they can see it and know then how to use it. Also, music therapy is going to be enhanced at Caron, and music therapy, it's the only thing, music is the only thing that uses every part of the brain. So it is so therapeutic and so healthy for them. And then also, we also use mindfulness, which is an excellent approach, which they oftentimes never even experience. Testing, we talked about a little bit. Our team of excellent psychologists, at Caron PA, we were using the MOCA at first. I know at Keele, they use the R-bands, and I think we use that at Ocean Drive. We also administer that if need be. The MCMI for personality testing. And then if someone did not improve in their cognition through treatment, I know we used to have we do have an excellent psychologist that administers dementia screening. And then also in some cases, the level of functioning, because that ties into, well, what comes next? Are they going to be able to go back home? Do they need assisted living? So all of that weighs into that decision of what comes next. So I said before, this population is a bit challenging at times. They're very unique, very diverse, ever changing, and absolutely rewarding to serve. We can actually, you can see patients get better, but with this population, you can really see them get better. Physically, they improve. Cognitively, usually they improve. Their spirit sort of comes back and alive. I believe it's never too late to not only develop an addiction, never too late to get sober. And I surely know it's never too late to intervene on an addiction. And with this population, that's oftentimes what families will use as an interventionist, because it is not an easy sell to get someone who might be set in their ways, used to the way they're, even if they're not functioning well, but even getting the families to move on it and say, now's the time we have to do something differently. We all need purpose and quality of life. And that's why we have the older adults. People would say, well, why bother? I actually had somebody, well, why does my 90-year-old grandmother need to come to treatment? And I would tell them, but she's not living quality of life. I don't care how long or short you live. It needs to be quality of life. So I thank you so much for attending. I will now turn it over to Kelly for questions. And it's been very much an honor to be with you all today.
Thanks, Sharon. And thank you, Dr. Krantz, as well, for that comprehensive overview of the older adult program at the Keele Center. We are very blessed to have both of you. You're both clearly brilliant, but also your passion is very inspiring. So thank you so much. We are going to shift gears now and go into the Q&A portion. Many of you submitted questions when you registered, so thank you for that. We have some great ones, but I also just want to remind everyone, you can use the Q&A feature in the bottom right-hand corner of your screen to ask a question, and we will hopefully get to it. And if not, we will follow up with you afterwards. First question is, in a lot of cases, adults have a partner who is also using substances. Can you treat couples together? Sharon, do you want to take this one? I know we have a lot of experience doing it in Pennsylvania. So do you want to elaborate on how we handled this?
Absolutely, we surely do. And it was a challenge at first when we had our first couple, but oftentimes the couples have been, as I said, married for so long that one does not want to leave the other side. And I have treated 2 alcoholics, 2 people dependent on benzodiazepines. It works really well. It's a very careful process though, because you don't want to breach confidentiality. So it's labor intensive, where you treat the husband or you treat the wife. You do sessions together, you do sessions separately, you do sessions together with family members, you do sessions separately with family members. So it is so much of a value though, because so many people do not do this approach. And you absolutely, if you're going to have 2 people living together, they need to be well together. If one is still continuing to drink, it will absolutely most likely take the other one down with them. So I love doing it. It's been well received. The community, they're actually happy to see that, because sometimes they even wish their loved one was in treatment. So it's been a great thing for us.
Thank you. And next question is, how often are older adults going into treatment for the first time? Dr. Krantz, do you want to start with that one? And Sharon, feel free to jump in.
Sure.
Okay, thank you, Kelly. So there actually are statistics on that. I believe it was 2018 that SAMHSA put out information regarding that there was about 1 million older adults age 65 and older that went into treatment for the very first time. So we're seeing more and more patients coming in treatment, whether you want to call it late stage alcohol use disorder, or again, because of the stressors in their life that Sharon spoke about, losing a spouse, losing perhaps purpose, stopping their job, retirement, being bored, all of the above, all of that helps escalate maybe the use of alcohol or any other addictive drug. And that's why I think we're seeing so many come in later on in life.
Thank you, Dr. Krantz. So we've actually received a couple questions similar to this, so I'll just combine them into one. And it's regarding the age of what we consider to be an older adult or who goes into this program. But one of the more specific questions says, in my practice, I've seen advanced stage addiction in younger patients. They've essentially become disabled. How do they fit into this group? So do you both want to kind of elaborate on what that looks like in terms of the ages that we see, and then how the younger patients would fit into a quote unquote older adult program?
Absolutely. I had the experience of treating several younger adults. We started with an initial age pocket group. However, we found that we couldn't stay in that box. And what we know is that we are medically and psychologically able to take very complicated cases, and thusly, we would have people. I treated 32-year-olds, I treated 37-year-olds, 42-year-olds, late stage alcoholics coming in wheelchairs, so compromised. We had two young gentlemen who had been in a coma in the hospital. Then they came into us, one of the only few places where he could be referred to. And then what I watched is the older adults really embrace the younger population. They sort of take them under their wing. The younger ones are so compromised at first that they actually fit in, believe it or not. And then as they get better, then they sort of lighten the spirit for the older adults. And the older adults give them encouragement that please intervene on this now. Please do this now. You do not have to be me. So don't wait this long to get well. So that was my experience at Caron, PA.
Dr. Krantz, anything to add on that?
The only thing I would add is that at Caron, we have the ability as a very integrated treatment team to reach across all disciplines, you know, the medical, the spiritual, the psychological, the psychiatric, in order to treat the whole patient. And what I mean by that is, like Sharon, I've seen like a 45-year-old come in that had a severe head injury because of a equestrian accident, and her head was actually, you know, sat on by a horse, and her cognitive abilities were not there, but she also had to learn everything else. Initially, before she came to us, she had to learn how to eat and talk again, and just the normal ADAs of life. When she came to us, I was concerned that the population that she was in, that it would be an issue for her and she wouldn't be able to express herself the way the other patients were. Well, once we started doing all the assessments like Sharon went through, you know, the integrative assessment as far as cognitive ability, the ability to do medical testing to see what the brain actually looked like and perfusion deficits in the brain, the one-on-one counseling, the spiritual care, all of that. Once we're able to do that and sit down as a team, we put a plan in place that this lady now is alive, well, cognitively intact, and her life is back. And we see these miracles over and over again. So it doesn't matter what the age of the patient is. We really see each patient and treat them on what their needs are. So they may not be 65, like Sharon said. It's not a cutoff that we have to adhere to. We're going to look at the whole and assess the whole patient and then put them into the appropriate program. And it's worked amazingly.
Yeah.
Thank you for that. Thank you for sharing that story. Certainly is a miracle. And, you know, I do want to touch on that a little bit with regards to Caron's ability to really create those hybrid models. So we've done a lot of that in Pennsylvania. And for this group joining us today, just want to let you know we are planning to do that with Caron, Florida as well. So when I say hybrid model, as many of you know, Caron has multiple programs within our continuum that specialize in a variety of different things, whether it's gender, age, occupation, drug of choice, variety of different specialty programs and specialty groups. So we're really grateful that we have all of that so we can truly create this hybrid programming for patients that may be due to an accident, a complex medical comorbidity, the progression of their disease. Maybe they need to be in some older adult programming, but at the same time, they could actually benefit from programming with some other people, more peer appropriate related people. So we will have that luxury at Caron, Florida, just like we have in Caron, Pennsylvania. So thank you both for answering that. The next question asks, what is the average length of stay, and can someone stay longer if needed? Sharon, do you want to take that?
Yes. We learned early on that 6 weeks should be the minimum. It takes a while for them to come back to life, so to speak, and it does take that amount of time to educate, have them physically be better, do all the family work I talked about. However, we had many patients stay longer than that. The more time, the better. The more time away from their substance. They come in so deconditioned. I think we talked about this the other day a little bit. They're usually malnutrition. They've been maybe drinking their calories, weakness of the legs, neuropathy, you name it. And it takes time to come back to life. Treated a lot of people with cirrhosis of the liver. And of course, the level of denial equals the level of sickness. So that means they've been in a tremendous amount of denial. It takes a while to break through that with not only the patient, but the loved ones as well. So more time, the better. And it's not to say that an older adult won't go to sober living. Sometimes they do. We've had excellent success. As I said, more time, better. If the longer you use or drink, or the more you relapse, you need more of something. So that could be more of time, more treatment, more Renaissance we've used Ocean Drive, we use sober livings that are appropriate. So more time is the best, in my opinion.
Thank you. I thought this was actually a really interesting question. I'm sure you both have experience with this, so I'd love to hear from both of you. How does this group being the older adult population, how do they identify with 12-step programming? And do they struggle with, being labeled an addict or an alcoholic?
They absolutely do. That's what I say. Resistant at first, some. If someone's been there, though, the beauty of it is if someone's had 12-step influence, they seem to spread the word, and it's more well received coming from a peer than from us. Mm-hmm. So for those who are resistant, it could sort of rub off on them. Also, we meet them where they are. If they are resistant, but we have many offerings at Caron too. It's not just about 12-step AA recovery. It could be SMART recovery. It could be Dharma recovery. So there's many avenues to go there. We have the 12 steps for the agnostic. So again, meeting them where they are, really differentiating between religion and spirituality, because they don't want things sort of shoved at them. And then eventually they embrace it. It seems to be, though, the stigma, like you mentioned, about their shame are attached to a label. So we're very careful. And I tell them all the time, I don't care what got you to these chairs. You obviously weren't functioning very well, or you wouldn't be sitting in front of me. So I like the fact that you got here. Now your journey is your journey. And eventually, usually they come to the point where they start feeling better. They want more of it. Again, they don't want to disappoint their families. So they're sort of willing at that point. I will say, and I forgot to mention this before, recovery coaching seems to work really well for this population. Mm-hmm. A recovery coach can sort of take them under their wing when they leave, get them to meetings, because that is pretty rough for them to go into this new meeting that I have no idea what this is all about, even though you've introduced it at Caron. So recovery coaching is a really good asset for this population as well.
Dr. Krantz, do you want to elaborate on your experience as it relates to the 12-step programming, but also the shame and stigma with the quote unquote labels?
Well, and I think Sharon did a great job in explaining that already. But yes, we don't stigmatize a patient. We don't say, okay, you're alcoholic. We try to, from a medical perspective, we'll try to say, well, this, and this is wrong, and the alcohol is enhancing this. So it's in your best interest not to drink alcohol at this point in time. And then we're going to discuss what your needs are and where we need to meet those needs. And the patient is very much part of the treatment team. And I think that makes, they have a voice in the decisions that we're making and recommending for them, whether it be length of stay or, certain modalities. Let's say they've had significant adverse childhood events, and that has aggravated their alcohol use. And now we're looking at that, and they may need trauma work or EMDR. So we really are a very individualized treatment program, and everybody talks about individual care, and I understand that, but we really truly do that. Yeah. So that the patient is able to understand what's going on with them, and this is why we're doing this modality, or this is why we're recommending this. They don't have, as Sharon said, they don't have to walk out saying I'm an alcoholic, because they have a better understanding of why they shouldn't be using alcohol, or perhaps that the benzodiazepines that they have been using to abate their anxiety is actually turning around on them after chronic use and causing more anxiety. So between the educational and the modalities that we use, we don't, like I said, we don't go for the alcohol use disorder. We just help the patient understand where they're at and what they need to do.
Absolutely.
Thank you. This next question, you both touched on this a little bit when you were speaking earlier, but if you wouldn't mind elaborating on it. It says, I've heard that adult children question, why is it worth it to send an older adult to rehab? What would you suggest we tell them?
That their life is still important, and that their quality of life it should be theirs, in the sense that treatment will help them use other non-chemical coping skills to deal with their stressors and identify their stressors. And they're, now maybe they're grandparents and they want to enjoy their grandchildren. I mean, treating any disease, whether it be hypertension, diabetes, or substance use disorder, is important to the quality of your life and the longevity probably of your life. So I don't care if a patient is 95 and they're having issues, we can help and definitely improve their quality of life, and every life is worth it.
Absolutely.
What is the oldest patient both of you have treated on the older adult program?
We had two 90-year-old females, 85, 84. And I will say, even if that person was coming towards the end of their life, this one gentleman, I so adored him. His name was Frank. He did get off the opiates. He had chronic pain issues, got off the opiates. His wife was still using back home. He stayed off the opiates, did medication-assisted therapy, and he did have heart trouble when we got him. So he lived about 6 to 8 months beyond leaving Caron. And afterwards, his family called us and thanked us. Thank you for giving our dad back for the time we had. We get a lot of that. There's no, oh, well, what didn't you? It's not like that at all. They are appreciative. And unfortunately, the families don't realize how deep they are into it, and the worries they have and the anxiety they experience when someone's not doing well. And we watch it in treatment. They get relief when they bring them in. They go through the couple of weeks, they're feeling pretty good. Then towards the end, when the person's ready to leave, their anxiety starts coming out again. And we try to normalize that, saying, you take care of you, they will take care of themselves with help. And then you all can have this quality of life, however long or short that is. I love the super aging presentation I do, because that's when you age 15 years you're less than your chronological age, cognitively and physically. And there is a way to do it, but drugs and alcohol are not involved.
Thank you. And this next question, I know this has come up a lot for me. For family members who are concerned about an older adult, what are some of the warning signs they should look for to know if, in fact, a substance use disorder may be present, or just substances in general may be exacerbating it? Because it's hard to know, okay, is it dementia, right? Because there's a family history of dementia, or because they are of a certain age, where you may expect to see memory problems versus is it a substance-induced memory problem, right? And then same with the chronic pain. They have legitimate chronic pain. They are prescribed opioids by a physician, but maybe they're taking those in more of a chronic fashion than they should have been used from an acute perspective. And then just same with the drinking. I know Dr. Krantz, you touched on this earlier in terms of when we age, our bodies metabolize it differently. But I think it is really hard for family members who aren't educated, right? Who are just unclear, or even clinicians in their private practice, to know what am I looking for? What questions should I be asking to know if in fact this is potentially substance use related and therefore they would be a good fit for Caron's older adult program, or is it something else?
So all of what you said is true. And even for physicians, like I've spoken to other primary care physicians, are you asking, the patient comes in and they've had, 2 falls and they broke their hip one time, broke their wrist another time, and maybe they have osteoporosis because they're aging and their bones are more brittle. But are we asking the questions, how much alcohol are you taking? Or did you have to take, more of your pain medication that may have made you a little bit blurry and you're slipping and falling? So it's really important to elicit that information from the patient. We see it often. And if it's a family member and their parent, has more cognitive issues, like say at night, yes, that can be certain kinds of dementia, but at the same time, in the morning, they seem to be better. So there's signs and symptoms like that. Again, the falls, the bruising. Gee, mom, how did you get that bruise? I don't know. We need to look at that. Their withdrawal, the isolation usually that we start seeing with patients, that they're withdrawing more to themselves. Maybe they're not seeing their grandchildren as often, or maybe they just, are staying in bed. I mean, those can all be signs and symptoms of an underlying substance use disorder that needs to be identified.
And sometimes it's not answering their phone. Sometimes you're having a conversation at night, you talk the next day. And again, we don't know, but it could be that a substance use is going on and they don't remember the conversation they had with you. Unexplained bruises for sure.
Right.
And we used to encourage people, like towards the end, if you were worried about your older adult, maybe accompany your loved one to the doctor, because you don't know what. And if you do have proof, I used to have patients, family members take pictures. But this is what your place looks like: disheveled. Everything's a wreck. Everything's a mess. You're not normally taking care of what you would do. So those kinds of things definitely are a sign.
Change in personality, like you're saying, Sharon, where they were compassionate and kind, and now they're short-tempered and they don't want to talk to you. Just simple things like that you may just, well, they're getting older, they're getting crankier. That doesn't have to be. I mean, we should be asking the appropriate questions.
Yeah.
Thank you. And I do want to mention that Caron offers a residential assessment program for all of our programs, but including our older adult program, where we often have patients come in who aren't admitting to a full length of stay for treatment, but rather they are coming for initially 1 week, 2 weeks for us to do a deep dive, a lot of testing that Sharon mentioned earlier, kind of peel back those onion layers through medical, clinical, and psychology, to really look at what is going on, what's primary, secondary, tertiary, and to develop a treatment plan, regardless of whether they need substance use disorder treatment or if it's something else. So I do just want to let attendees know that is a program that Caron offers for the older adult population as well. I want to be mindful of time, and we've got just a couple more questions. So let me try and get through these. And again, questions that we don't get to today, we'll certainly follow up with you. what is the projected opening date for the Keele Center? So I can actually take that one. We are slated to open in January of 2023, so just a few short months away. We will certainly be keeping everyone in the loop with the exact opening date. But as of now, we are shooting for January 2023, and I have not heard any reason why that should not be a realistic opening time. And really quick, whichever one of you would like to take this one, but do we look at nutrition and how is that incorporated into their treatment stay?
I would absolutely must stress that this is done for all the patients. Every older adult gets a dietary consult. They have an expert come in. And then if they have dietary needs, that is ordered from the from the kitchen staff, from the chefs. So it's absolutely one of the key components because, as I said, oftentimes they come in quite malnutrition and not taking care of what they need to, and especially those with diabetes. If someone needs a special snack throughout the day, that is delivered to the unit. So it is something that's followed. If they have somebody on their radar that needs following throughout treatment, they see them as often as need be. My experience at Caron, PA, anyway.
Yes, and we are very grateful that we have licensed dietitians here that will be working with our older adult patients, with all our patients, but again, to meet those dietary needs, to give them the information, how do I decrease my cholesterol? How do I have a better quality of life nutritionally that will affect my whole body? So they are very much involved in the treatment team. And as Sharon said, even working with the kitchen staff that to make special meals, we'll be able to do that also. So very important point.
Absolutely.
Thank you. And I've always been very impressed by what our older adult unit does as it relates to nutrition and just overall physical health and wellness, right? Sharon, I remember you said this to me years ago. I've never forgotten it, that motion is lotion. Absolutely. And you were talking about the patients and the benefits of getting them up and moving and exercising and looking at their diet and why it's important even at 80, 85 years old to look at both, from a nutritional aspect as well as just a physical fitness aspect. So I've always appreciated that about this program specifically. I know we had a couple of questions that we weren't able to get to, so please know we will follow up with you individually. I just want to be mindful of everyone's time today. Appreciate you being here with us. So thank you for joining us to learn about Caron's older adult program at the Keele Center. Someone did ask, are we discontinuing this in Pennsylvania because we're opening it in Florida? The answer is absolutely not.
No.
We will continue with the older adult program that we've had for a very long time in Pennsylvania. The older adult program at Keele will just be an addition to an already robust continuum. We hope you join us for our next webinar in the Countdown to Keele series, which is going to be on October 19th. This one will be specific to detox and stabilization, and Dr. Anthony Campo, who is the medical director of Caron, Florida, will be leading this webinar. Additionally, please watch out for your email for other educational opportunities through Caron, specifically our continuing education webinars. And lastly, we would love for all of you to register for our 7th annual Addiction Research Symposium, which is happening on November 4th. It will be both in person at Caron, Pennsylvania, and there will also be a virtual option for the program. And the Research Symposium is approved for 6 AMA Category 1 credits. Finally, please reach out to your local regional resource directors for any questions you have on this, or if they can be a resource for you as it relates to any programs at Caron. And thank you so much. We hope that you enjoy the rest of your day. Take care.